Hi everyone, thank you very much for allowing me to be here. And I guess I'm going to start this talk. There's a little bit that will be repetitive, I'll go over quickly, but I'm going to start this talk because this is our experience of possibly where some members of the audience are, which is what happens with the very worst patients. It's probably not the place to start, and hopefully what we're going to be doing is kind of encouraging an earlier set of referral patterns, treating smaller lesions and developing expertise. But this is quite an honest appraisal of some of our experience in Cork, and this is based on a paper that we've recently published, but for the treatment of intractable cutaneous lesions. We all know about the problem of cutaneous metastasis, and breast cancer is an incredibly common cause of cutaneous metastasis, and the cause of fungating wounds which impact hugely on the patient and their quality of life. This, is a little thing to say for those that don't know, the Republic of Ireland, Cork, we're there in the sunny southwest of Ireland, based right at the bottom there. But the problem of fungating wounds is a huge one, and this is one that we kind of had a little think about and wanted to address. We know where the disease can come from. There's no really point in dwelling on that. And we know what it means, that there's advancing disease, and really the impact on the patient is the burden of disease, this visible reminder of their disease and their disease progression, and possibly a slant from curable disease or hidden disease into something that's much more tangible. And so in that, the quality of life and the effect on patients' quality of life is really quite marked. And in it, possibly moving to the answer of one of Jackie's questions, I think grasping that provides us with some of the answers of who do we treat and why do we treat? And I think actually that's what we've got to be considering. And I want to show you a few quite honest cases at the end of why I might have treated people for completely conflicting reasons, but all based around them and their quality of life. I'm not going to dwell on the other options available to patients. We all know this. But some of them have got limited applications. Some of them might not be suitable. The patient's disease status, their previous radiotherapy may exclude them, their surgical options may have run out. And these patients that I'm going to talk about here are patients that had basically reached the end of the MDT pathway and came to us in our earlier days of treating with electrochemotherapy because really they had no better or other option. You understand, and we've been introduced to the idea of electroporation and transient membrane porosity. And I'm going to this is a little slide from the lab. We're lucky in Cork that we have quite a strong background research interest, and these are from some of my colleagues in the lab. And really what this shows is, if you look at the pictures on the far right, if you electroporate by itself, these are breast adenocarcinoma cell lines. If you electroporate alone, it doesn't do anything. If you add in electrochemotherapy, if you add in the bleomycin along with the electroporation, in the middle we've got tunnel stain, so the green ones are cells that are dying, and on the far right we've got a flow cytometry. So essentially what this shows is that the process of electrochemotherapy is very efficient at treating breast cell lines, and we can replicate that in the laboratory, and this is some of our own data on the difference between the control, which is obviously nothing, bleomycin alone, electroporation alone, and electrochemotherapy, which is the blue line at the bottom. And very similar to the data that Jackie was showing, we can see in a murine model a very distinct difference, and it is the combination that works. I don't need to show you the equipment, but I just talked to you. This is our data. This is the kind of the Cork experience of electrochemotherapy. We've been treating patients since we were part of the ASOPI study, so the setup for the standard operating practice in electrochemotherapy. And what's kind of interesting is that as a group, electrochemotherapy has brought in all sorts of different practitioners, with different hats on and different approaches. And whatever we come to it from, there is a remarkable consistency of response across things. And I think these are our own data, but they're fairly similar. I think if our complete response rate is just a fraction lower than everyone else's, but the overall response rate is very similar, with an objective response of approximately 84%. And we have an experience of, this is a little bit outdated, of about 120 patients that we've treated in Cork with a variety of diseases. So we look back specifically at our breast data to have a look at who did we treat, what was the disease burden of them, who responded, and to have an idea of what kind of treatment modalities they had before. This has the weakness of many retrospective studies. This is a retrospective analysis. It's a heterogeneous group of patients. Some included in this OPI study, some not, some treated under general anaesthetic, some not. But I think it's reflective of the broad experience, because of course people come with different disease and different intents. The demographics, 23, this is data on 24 patients, 23 ladies, one man, relatively young, but I think symptomatic of the disease we're talking about, and with you can see, an average of 56 years old, a large age range, and the kind of expected disease progression. Some people that have a rapidly progressing disease that have presented with cutaneous metastasis, and others that have had very slow evolution, so for up to 15 years. I'm not going to explain all of this, and apologies for the numbers, but the take-home message of this is that if you start in the top, that corner, top left-hand corner, most people have had some surgery. Most of them have had some neoadjuvant chemotherapy, so either adjuvant or neoadjuvant chemotherapy, adjuvant or neoadjuvant radiotherapy, and a variety of hormonal treatments as well. And they've had some surgery with adjuvant radiotherapy and hormonal therapy, surgery going across the bottom of the kind of various parameters that there is. But I think this represents, to me as a plastic surgeon, the group that you and we all treat, people that have come in that have had a variety of surgery, systemic chemotherapy, radiotherapy, and or hormonal manipulation. We were able to look at, within the 24 patients, there was 242 nodules in total, 161 at presentation and some that came on afterwards. Inevitably, with this population, we lost a huge number, or some to follow up. Some remained untreated, and there is 34 of them. So, a reasonable percentage that were lost to follow up, either because of progression of their disease or inability to attend. But this is 202 lesions that we're going to present on here. Of those, the response rates are reasonably good. The complete response in 130, so just over 50%, a partial response in another 30. Some that have no change, and I was talking to Dr. Gail, who you hear from talking earlier on, is one of the things what I still can't put a finger on is how to identify those people that don't respond. I think that's something that we'll need to learn as we go on. But a huge number of patients that have had other treatments that are actually responding and doing quite well. An objective response rate of approaching 80% in patients that were deemed unsuitable for other treatment groups. And a patient response, because of course that's even better, of 75%. When we drill down in that, there's few patients, unfortunately, only a handful. I think there was 3 or 4 that actually had a complete response from the treatment that they had. But I think this represents a significant decrease in disease burden for those patients affected, and patients on the whole are getting some objective response from their treatment. I mentioned there's some that we don't know the answer to. We don't know why they progressed. So if we look and interpret these results, ask the questions, are we treating a population with an inherently favourable prognosis? I think the answer to that is no. But are there factors within it that make ECT more likely, make it more likely to have a favourable response? And there are, and these are becoming increasingly well established. Certain things that improve the chance of responding. And within that, so we had a little look at, so this is from this, but I think this is something that's replicated really across the board and is, to me as a surgeon, I think is relatively intuitive. I'm intrigued by the sort. I think oncologists don't necessarily find this as intuitive as I do as a surgeon, because as a surgeon, small problems are easier. And this is looking at response according to size, with complete response in blue and partial response in red, and no change in the kind of creamy yellow. And you can see quite clearly that as the lesions increase in size, the likelihood of responding completely does diminish. And if we can send that as a take-home message and hopefully begin to draw people in for treatment earlier, I think that'll be a good thing overall. So the smaller the lesion, the more likely it is to have a good objective response. We looked at our local disease control, quality of life and survival. This is a very small cohort. I'm kind of cautious about drawing conclusions from it. This is a really small cohort of people. But for what it's worth, they appeared as a little group to do a little bit better than average and a little bit better than controls that we looked for and matched them from a non-treated population. So their median survival was pushed out a little bit, but I think it's quite hard to extrapolate from this, but it'll be an interesting question. We know in other disease states that decreasing disease burden does actually have a small impact on quantity of life. But I think the most important thing that this has is a very strong impact on patients' quality of life. I'll show you a few little case examples, as I wrap up. And feel free to comment and ask things, and I'll just try and give you a flavour of how or what patients came for treating. So this is you can see the chest wall of somebody that's a very scarred chest wall after surgery and radiotherapy, and the sort of skin that would get your surgical colleagues looking at and possibly walking away from. But with relatively small volume disease and electrochemotherapy, this lady who's afforded good local control on the chest wall. This is a picture. The next two actually pictures that are in your brochure, but these are a similar condition with slightly better quality skin, but a difficult area to get strong cutaneous control, but lesions that have responded well to directed treatment with electrochemotherapy. But a conversation that I find myself having increasingly, and as a surgeon, it's something that I find it's harder to have. I'm used to the mindset of coming in and having a definable problem that I can make better. So the idea of not having a definable problem and not being able to make it better is something that I find harder. But what about the patient who has a wound that is just deteriorating? Is the idea of actually giving them stable dressings or dressings that are easier to manage, that's actually a good achievable goal, is it not? One where you can stop potentially the odour in a wound or other such slightly non-tangible bits. And this is an example of a lady with inflammatory breast cancer, was treated very early on in our series, who had 3 ECT treatments, and she was never trying to be cured. We're never trying to get rid of this. But what this has done is afforded her some degree of disease control, and that, I think, is actually a very good benefit. And I think about this lady quite a lot. This is a lady who was referred late with an incomplete excision and really quite aggressive cutaneous recurrence. And for her, the fact that we actually gave her some visible shrinkage and visible control was a good thing, and something that ultimately improved on her quality of life and her well-being. But I'd like to hope that by the end of this meeting that those people referring into electrochemotherapy services would try not to let things get to this state and would remember that earlier treatment is often better. This, of course, is the the sort of case that we'd all love to have. This is a young lady that was referred in at age 43 with a very young family with these cutaneous lesions. She was one of the first patients that I treated when I took over the electrochemotherapy service, and 3.5 years later she was still alive and doing well. She's actually completely lost to follow-up at the moment, but it's a fantastic, this is a very defined chest wall disease, treated early with a whole response. But taking you through it, just to give the top left-hand corner, is gives you an idea of actually what can happen during the course of the treatment. You expect the lesions to sort of involute, and in doing that we hope that the lesion will turn into a sort of eschar and a dry bit of scar, and that's what's happening in that top corner. And it can take several weeks for these to heal up and to delineate and fall off, but ultimately with a bit of dry eschar it's quite easy to control, and ultimately she did very well from it. So what does this show? This is a little introduction to talk about that we've got good evidence that electrochemotherapy is effective in experimental models and in practice. There is evidence that electrochemotherapy works even in the very difficult patients. But in order to get it to work as well as possible, the disease burden, it does matter, and ideally the smaller the lesion, the better. But ECT should be included. It's not a panacea. It's not going to change everything. But it certainly is a very good option for targeted disease control. Thanks very much. Any questions?
Hi. I just wanted to ask, because I'm based in Singapore at the moment, and we do have a lot of skin occurrences.
Yeah.
And the problem is they leave it too long, and when we scan, CT scan them, it involves the chest wall, the muscle, and sometimes the actual bone in the chest wall. Do you still treat them, or?
Funnily enough, I took out a slide on the tube on the way in of somebody like that. The answer, it's a much harder one it's a much harder call. On occasions, yes. If I think that there is a symptom that I can make better or something that I can improve for them. So my own experience is that ulcerating, fungating wounds are very difficult and very stressful and very problematic. And so even keeping something flush with the skin surface might provide an advantage, but it's the one I struggle with the most.
Or would you push the needle into the muscle?
Yeah.
It's muscle.
Depends.
My only worry is that would there be a hole in the chest wall?
It depends where you're pushing it into, and of course you have to be strongly aware of the structures underneath.
Yes.
On the whole, electroporation-based therapy is selective towards tumour as opposed to non-tumour, but I don't trust that completely.
If I just add a comment, I find using a linear probe actually for the muscle reduce the intensity of the contraction as well. Perhaps one can, provided the area that you're treating is not large areas, perhaps a linear probe would be nice.
So maybe you can just treat the superficial part, leaving the
No, you can go as deep as you want, as long as you have got some sort of control to measure. I mean, sometimes I use ultrasound with the procedure so you can see the depth where you're going.
You have experience with, I think the problem, what I experienced is that if you have the lesion going far down and going through the layers, then you have a problem because all tumor gets necrotic, and if you don't have new tissue which is growing in there, you actually do have a problem. For example, we had problems with cutaneous metastasis over a cord, implanted cord, okay. They were easy to treat, but then there was necrosis, and then of course the cord had to be taken out because there was no skin left. And I had one case where I had a similar to your picture with those little metastases, but it was in the pleura, and there I did not want to treat because I was you have experience with that. I was afraid that if I get the necrosis within the pleura, I get a pneumothorax.
No, very good. But I mean, I just two comments. One is that I think we've inadvertently started focusing on a very, very specific subset of patients where there's a very three-dimensional thing that I think is very rare and doesn't really represent the common. And so I just kind of put that caveat on the conversation. But to answer, we have experience of treating chest lesions. There are ways of electroporating lung parenchyma because of that, but that's a sort of that's all experimental things at the moment. But essentially, all tissues are amenable to electroporation. You just have different considerations. Hi. Sorry, your two hands up. I'm delighted.
If we start at the back there.
Looking at the large lesion that you've got on the chest wall, and having seen some of the our surgeon doing it locally,
Yeah.
I thought there's a distance. How long does it take you? How many incisions that you have to make in order to treat that sort of lesion? Because we usually reject those and say it's not appropriate. I was intrigued in how such a good result you get. How long does it take you to do these sessions? How many insertions? Do you use multiple needles, or I can't?
So the inflammatory picture, so the one that was covering a large area, is that the one you were
20 by 20 centimeters.
20 by 20 centimetres. So there's very clear, we have got a very good understanding about the kind of pharmacokinetics of bleomycin, and there are guidance on how long a procedure could and should last. Ultimately, to try and make sure that the bleomycin is as a high level as possible. Long story short, you can treat for up to, the guidelines that we're about to produce, or we're producing at the moment, suggest that you can continue on pulsing for about 40 minutes, and so you can actually cover quite a large area. Choosing different needle arrays helps you cover large areas, but essentially that's the kind of case under general anaesthetic with tap dance to the feet, and then you can treat quite large areas. You have an effectively a 40-minute treatment window.
Thank you.
So my question was related to that really, and that's about, is this a one-off treatment, or is it something you can go back and repeat next week, next month, next year?
So there's a total lifetime dosage of bleomycin, and the higher the amount of bleomycin that you have, and sorry, we're talking nearly exclusively about bleomycin, but the European experience is that we tend to use bleomycin as opposed to cisplatin. There's a total lifetime dosage that you can have. Your risk of pulmonary fibrosis increases with increasing dosage. But this is a treatment that is repeatable. On the whole, it's one treatment, watch it for a month and see what's happening. If there's evidence of continuing response, I would tend to leave them for another month and tend to, if at all possible, have a 2-month window between treating people. But which makes it quite a low impact treatment, quite a low impact when you compare to radiotherapy, multiple hospital visits and that kind of thing. But yes, you can treat people multiple times. Within this group that I've talked about here, some people were treated up to 7 times, and treating in other disease states, we frequently retreat either for new disease or partial response.
I would imagine the larger your lesion, the more likely you are to need to go back and treat it again.
Yeah. Yeah, the lower the response rate, and the more likelihood you are to go back. Yeah, but it's you can patients tolerate several sessions.
Sorry.
Question.
I was going to say you allude to the lifetime dose of the risk of pulmonary fibrosis
Yeah.
with bleomycin, but
Yeah.
you can stick it into the tumour.
Yeah, yeah. So bleomycin can be given intratumorally or intravenously, and there's preference depending on the number of tumours, the number of their distribution around the body, the likelihood of covering the margins as sort of clinical parameters. But essentially you can decrease the dose by putting it into the lesion if you think you can get good penetration throughout the lesion. On the recommendation is that once you get beyond the 3 square centimetres, that the lesion is more likely to do well with intravenous bleomycin. On the whole, we try and stick rigidly to the two. You could occasionally think of combining the two, but that's slightly more left field.
take one final question from Linda.
With intravenous bleomycin, is previous radiotherapy ever worrying you with regard to, because when we give radiation to breast or chest wall,
Yep.
especially if they've had radiation
Yep.
to the supraclav, there is some level of lung fibrosis.
Yep.
Would that ever worry you about giving intravenous bleomycin later on?
Very good question. So yes, it worries us on two levels. One from the pulmonary perspective. So it's important that if you're giving intravenous bleomycin, that you have a baseline understanding of their lung function, so their DLCO, their diffusion capacity, which should be above 55%. So if you're contemplating intravenous bleomycin, it's worth having, well, you should have baseline lung functions to have a look for that cohort of patients, and possibly think about repeating it if there are multiple treatments. We know that electrochemotherapy is not quite as good in post-irradiated treatments. In the NSPEC database, we've got a number of patients treated for a variety of disease states. And the more fibrotic the tissue, the kind of harder it is. I think that's my time up, is it? The more fibrotic it is, the harder it is to get good penetration, the harder it is potentially with the blood supply to get the bleomycin in. So there is a slight fall off, but even so, there is very good response in pre-irradiated fields, and that shouldn't put you off. It should just, I think you just need to go into it with a slightly more realistic ambition.
Thank you very much. That was
Thanks very much.
fascinating.